to participate in these grand rounds, and I'm very grateful to Dr. Marsh for allowing us to do this, because I thought that Dr. Deshmukh is a special fellow, and he came here. I know him over the last 7 years. Dr. Rutland and I invented him in Milwaukee, and when I knew that I was going to come here after signing my contract, I gave him a small secret and told him I'm coming here, and I asked him to apply for our cardiology fellowship program. Dr. Smith was very nice to give him a chance to interview, and he came here. Over the last 3 years, he has published more than 50 papers, and he has had more than 50 abstract presentations. And in November, at the beginning of November, Dr. Deshmukh had a paper as a first author published in Circulation on complications of atrial fibrillation ablation. So I thought he deserves to talk about this part and tell him his research. He'll do a better job than I do, and I'll take it over at the end to go over the future directions with atrial fibrillation ablation.
Over the past 6 months, I also do a better job of making complications and creating complications. So I'll give my spiel about how and when complications can occur. So this is the worldwide survey which had looked at about 100 operators all over the world, and they quote that their overall complication rate of atrial fibrillation was about 4%, 4.5%, but this is again like the best centers in the world, and all these co-authors are like who's who of AFib population in the world. But again, this is not what the real world would suggest. So where would normally complications would occur? So you can have vascular complications, you could have post-op hemorrhage requiring transfusions, you can have AV fistulas, and you may have it at times so bad that you may end up requiring a vascular surgery. Now the reason why we would have vascular complications, because we access both the femoral veins, right and left, and we put sheaths which are about 8 French and about 12 French at times to gain access into the veins and then into the heart. The patient is fully anticoagulated with the ACTs maintained over 300. So that's why it's a very high chance that you're going to have a vascular complication. So these are the reasons why you have vascular complications. As far as cardiac complications are concerned, you can have all sorts of pericardial complications. You can have acute myocardial infarction. And again, as you would have seen on the earlier pictures, you have 2 transeptals. You are moving 2 different catheters in a very small left atrium in a patient who is probably most of the times NPO and dehydrated. So the atrial size is small. So there are more chance of having cardiac complications. On top of that, the patient is fully anticoagulated. Again, as the procedure is long, you are going to have prolonged intubation times. There is a chance of pneumothorax, and patients may require prolonged ventilatory support after the procedure. You can have strokes and TIAs. Now you can have strokes at 2 different times. You can have stroke during the procedure, because at times inadvertently you could have a thrombus in the left atrial appendage which could have been missed on TEE or intracardiac echo. And at times you also have to cardiovert the patients. At that time there is also a chance that you can have some stroke. People have also looked at that patients may have silent strokes at the end of the procedure, and that's because you're ablating so aggressively in the atrium, you can have silent stroke, and this has been proved on diffusion-weighted MRIs. The delayed complication, I'm not going to go into the pulmonary vein stenosis because Dr. Pildak alluded that a lot, but you can have delayed tamponade, which we have seen. You could have delayed strokes, and you can have atrial esophageal fistulas. Now, why would you get other cardiac complications in AF ablations is because of the anatomy of the heart and anatomy of the other neighboring structures around it. Immediately posterior to the left atrium, you have the esophagus. You also have the posterior wall of the pulmonary vein. So there is a high chance when you're ablating there, apart from stenosis, you can also rupture and tear off that vein. You have mid-coronary sinus, which is again posteriorly directed, and along the coronary sinus you have a circumflex artery. So again, if you're burning too hard there, you can have an acute myocardial infarction. You have the esophageal arteries right behind the atrium. You have a lot of pericardial and esophageal AV drainage, and you have all sorts of azygous veins and lymphatic drainage. So there is a high chance, again in unskilled operators, that you can injure one of those important structures, and that can potentially lead to catastrophic complications. This I wanted to go a little bit in detail. So this is where your left atrium is going to be, and this is where your esophagus is. There's really hardly any structure or anything behind the left atrium and the esophagus. There is just at best a thin layer of fat. That's all it is there to separate the left atrium and the esophagus. And when we are burning in the left atrium, we are usually burning at about 30 watts, 35 watts. And if you're burning so hard, it is very, very unlikely that the resistive heat, what you're creating by burning in the posterior wall, can get transmitted into the esophagus. And you can have esophageal ulcerations, you can have reflux symptoms, and the worst complication you can have a fistula between the atrium and esophagus. So you can imagine if someone is eating and everything goes into the left atrium, that can be a catastrophic situation, and the mortality after this is reported to be more than 90%. So this is something we have to be extremely careful about. Now in our paper, when we looked at different sorts of complications, and this was a national study for 10 years, we looked at about 95,000 patients. The most frequent complications were cardiovascular, then the vascular complications, respiratory, strokes, infectious complication, and about 0.46, so about 4 in every 1,000 ablations what we are doing, there is a chance that you can have an in-hospital death. When we looked at each complication more specifically, the most frequent complication was post-op hemorrhage, and that's again, as I alluded, you are using aggressive anticoagulation, your ACTs are very high, and nowadays you're also doing this procedure when the patient is on full Coumadin or is on dabigatran. So again, the chance of having a vascular event or hemorrhagic event is much higher. As we are getting better, with this, some of the complications are decreasing. The overall trend is still increasing because I feel that's predominant because of the denominator, which has increased significantly. But you still have an increase in your pericardial complications. You still have an increase in your respiratory, in your pericardial complications. But the number which has gone down is respiratory complications, because nowadays we have innovative techniques like high flow ventilation, which we are using during AF ablation, which has reduced our respiratory complications. So those are some of the things which have changed. And stroke and TIA again has gone down steadily because again we are doing it on full anticoagulation. And again, if you are fully anticoagulated, the less chance you are going to have a stroke. The most important message what we found, that your complication rate can be as high as 7% if your annual operator volume is less than 25. And it can be significantly low among all the expert references apart from mine and Sandeep and what Dr. Pedak quoted, that if you're doing more cases, you can have about 2% complications. So again, if you're doing less cases, you'll have a much higher complication. When you looked at different hospital volumes, again, if your hospital is a very busy hospital for AFib ablation or you have a dedicated AFib center, you can have complication rates which are much lower compared to hospitals which are doing AFib sporadically and their complication rates are a little higher. So this is what you should know. And then when we compare these complications from more real-world studies like Medicare data or like something what we did or these various worldwide surveys, and then when we compare this with all the randomized controlled data which has been published, you know, our numbers around 6.297%, 9% here are these numbers are much higher than what has been quoted in the most well-quoted randomized controlled trials. So again, this is something to know that you know, real-world results might be a little different than what you would see in good and well-controlled randomized controlled trials. So, like Dr. Pedak said, who would be the best patient or who would be the ideal patient to do an atrial fibrillation ablation? So again, the person should have severe symptoms. He should have a small left atrium, younger patient, paroxysmal AFib, with no structural heart disease, and otherwise should be healthy and not have many comorbidities, and should be a thin person compared to all of these people, and then you're going to have better chance of success and efficacy and less complication. But I think apart from this, what the piece of the puzzle which was missing, and we got an elegant editorial for that, when it really comes to complication, the operator experience and the hospital experience does matter, and that would also be one of the most important things to prevent complication. So once I take all the blame for complications, I'll hand off to Dr. Pedak.
I asked Dr. Deshmukh to talk about complications, not that he creates complications, but he's a stellar fellow, and after finishing his EP fellowship with us, he's going to go to his dream center, Mayo Clinic, to do 2 more years of further training in electrophysiology and complex ablations, and hopefully he'll come back to work with us as a faculty in the future. I'm going to finish up our talk with the future aspects of atrial fibrillation ablation. Recently, Dr. Sanjay Narayan and his associates from University of California in San Diego have taught as